What a friendly, lovely audience. Anyway, I'm pleased to be here, and it seems that healthcare policy gets people's attention these days based on the turnout. So pleased to be here and talk about some of what's going on with you. Who in the room remembers Hillary Care? Pretty much everybody. It's an old group. In any case, but sort of hearkening back to that and thinking about the fact that healthcare policy is so complex, and obviously that was a very complex proposal, and it maybe fell apart partly because of its complexity. But it does seem that we have some real difficult kind of quandaries to work through in the U.S., and I think one of them is that we feel like we have an obligation to treat. So if somebody gets really, really sick, the assumption is they'll be taken care of, and yet we really not so sure that we think there's an obligation to have health insurance, and so we end up with uncompensated care and cross subsidies in the system, and commercial or private payers having to pay premiums to help offset the uncompensated care so hospitals can stay viable, and so on and so forth. And I think that's a lot of what the Affordable Care Act dove into to try to address. Anyway, so the design of the ACA, I just want to talk briefly. The notion was you get everybody into the system one way or the other. There are heavy protections for those with chronic illnesses and those who are in older age groups, because insurance typically is far more expensive because costs are much higher for, say, the 55 to 64 group. And of course it gets worse as you get older, but you have Medicare. Pre-existing condition protections and so forth. The Act required certain essential benefits in order to be recognized as insurance, and that certainly has been controversial, but at some point you have to define what insurance is, and so the Act defined what insurance was with pretty substantial coverage. And then there are the subsidies or Medicaid coverage for people who are low income, because obviously they can't afford it on their own. And so in order to get them into the system, there needed to be subsidies or Medicaid coverage. In terms of Medicaid, the move was really away from categorical coverage. And for those, this is going to bore some of you, but Medicaid had much different standards for coverage, and actually still does, for children, say, where it went up to 200% of poverty if you include the children's health insurance. And then it had lower, but still maybe 100% of poverty or so, and then different amounts for waivers for the disabled and the aged. And then for more able-bodied adults, at least those that didn't qualify for disability, we had very low standards in the state. It was around 50% of poverty, and that was only if you had a minor child in the household. And if you didn't have a minor child in the household and you were between 21 and 64, you're out of luck. And we came up with this adult benefit waiver program, and it didn't include hospital, and it was capped at $60,000 and so forth. So the Affordable Care Act set the stage for Healthy Michigan, which changed the rules to just become just based on income. So if you're low income, you're on Medicaid. And the notion was to get everybody covered. So it went up to 133% of poverty, or 138 if you include the 5% income disregard for Medicaid. And then above that, you had these decreasing subsidies all the way up to 400% of poverty. The notion being that's the way to get everybody in the system, and of course it included mandates and so forth. So, Michigan's response. So, for those of you who recall this, Governor Snyder was fully supportive of the Medicaid expansion, and he included it in his executive budget. And he also was in support of a state-based exchange for the administration of the subsidies and the coverage. And so I think one of the houses passed the state-based exchange and the other decided not to. I don't know if they defeated it or just didn't vote. So that never made it. And then, of course, the Medicaid expansion was not a part of his budget. It was passed by the House in June, and then the Senate sort of deliberated the entire summer and finally passed it at the end of August, and without immediate effect. So we actually got 3 extra months to prepare for an April 1 implementation, which I have to tell you was incredibly helpful, because there are all the problems with computer systems and things, and we were able to, I think, get the IT situated in such a way that it worked quite well. But the design of the program was really heavily influenced by the legislature in terms of wanting to bring in principles of personal responsibility and accountability. The notion being that, you know, there needed to be skin in the game. Those that were benefiting from the system needed to understand that there are huge financial obligations, to try to start to familiarize those that were beneficiaries with the cost of care. And so we created these My Health accounts that sort of have an HSA type of flavor, but most of the money going into them was coming from the state, not from the individual. But nevertheless, to try to give the beneficiaries a picture of the care that they were getting and the costs, and then to have incentives for healthy behaviors, so that we had this health risk appraisal, and the primary care physician was meeting with the beneficiaries at their initial get-together and looking at the health behaviors and issues that that individual felt they were facing, and they could make a commitment to work on one of 6 or 7 domains of care, and then there was supposed to be a financial reward at the end of that, although it was a fair distance in terms of time between getting your doing whatever you're supposed to do and getting your reward. And I think the behavioral economists would think that maybe we should relook at that. But in any case, so we had this design so that folks would get healthier. They would, the notion being that they get healthier, maybe they could earn more, maybe they could move out, earn more income, move into more private insurance coverage, maybe the employer would pay for it, or they could move to the exchange and get a subsidy. And there are even aspects of the legislation that automatically would move people over 100% after 4 years. So, so we got Healthy Michigan, April 1 of 14, I think. I hope I'm in the right year. I've gotten old enough, the years just all blur together. But we had a relatively smooth ramp up. The IT system worked. People got enrolled. 600,000 by the end of the first year. I read 618 in the little pamphlet that was put together for this. I thought I heard the governor say 640,000 last night. But in any case, over 600,000 people are being served on the program. Amazingly good access. I heard very few stories of difficulty of people getting to the physician, and we were doing a lot of work because the legislation required that a person have an appointment, not see the doctor in the first 60 days, but have an appointment in the first 60 days. And so we watched that pretty carefully, and that seemed to work well. So amazing response by the physician community, I have to say. I mean, very gratifying, the commitment that was made. So in terms of outcomes, certainly a large volume of preventive and more routine physician visits. We rely on private health plans for the most part, same as we do for the regular Medicaid program. And then last night I heard the governor, as I was doing an errand, that he was very positive about the program and indicated that uncompensated care had gone down. And I don't know if it was 45% or 50%, but something, a very, very significant decline in uncompensated care. So here we are. We have this program, Healthy Michigan, Medicaid Expansion, 100% funded up until I think this year, and now it's maybe 95% federally funded. And we have a new administration and a new Congress, and nobody knows what's going to happen. And I think I'm going to talk more about that at the end as opposed to right now. But I do want to comment a little bit about the new administration. I think the proposed Secretary Price, Representative Price, is being grilled by the congressional panel right now. I think he was on public television or CNN or something as I was leaving our building. But the proposed CMS administrator is Seema Verma. And Seema was a health consultant in Indianapolis. She had tremendous influence on the Indiana Medicaid program. And she was really, I think it's fair to say, she was an architect of Healthy Indiana, which really did predate Michigan. And so she was involved in Indiana, in Iowa, I think in Idaho, and maybe a couple of other states, putting in many of the features that we put in Michigan. And she did a little bit of consulting with us as well, but was more heavily involved in the other states. And so this notion of personal responsibility, having every individual pay a premium of some amount, even if it's relatively nominal, rewards for healthy behaviors, and effective utilization. And there are, I think in some states, including ours, there's some kind of disincentive tied to inappropriate use of the emergency room. So these are all features of trying to have personal responsibility and accountability built into programs. we have this, and I think it's fair to say that given SEMA's background, it's likely that there is going to be a great deal of sympathy on the part of the administration to designs like Healthy Michigan. But I think the question is, what will Congress do in terms of the broad stroke? And fundamentally, no matter what they say about policy, it's all about the money. So what will really matter is whether there's sufficient funding for the state to continue the program. But in any case, it seems like we've arrived in a pretty good place. I know other speakers are going to talk in more detail about Healthy Michigan and how it's going from an economic standpoint and evaluation standpoint and so on and so forth. So I'm going to sit down and turn it over to the next speaker.